Hi, everybody, and welcome. I'd like you to meet our dentist. We have Dr. Mark Garner on the left there and his brother, Aaron Garner, on the right. Dr. Mark is graduated from 2006 from Nebraska Medical Center College of Dentistry with his Doctor of Dental Science degree. He was one of 4 students inducted into the National Dental Honor Society. Now you got to help me with this. Omicron, you say it.
Omicron, Kappa, Upsilon.
Thank you. My teeth won't let me say that. All right.
Okay.
He has given back to his community. In fact, all of them in this office, that is what they do. He was a part of starting Dentistry from the Heart, where you open your practice, 2 days out of the year or so, and do dental work for anybody that needs it.
Yep. No questions asked, free dentistry on
And then
those 2 days.
You've also done Freedom Day USA. Can you explain what that is?
Yeah, it's the same kind of thing as Dentistry from the Heart, but it's focused specifically on veterans, our veteran population that don't have access to care.
That is awesome. I think that is really nice because the veterans also suffer.
Yeah, well, I was in the Air Force for 6 years myself, so I'm a veteran, and so I just feel like we kind of got to take care of each other sometimes.
That's true. That's true. My husband's a veteran, and he'll totally agree with you.
Yeah.
You're also a member of the American Dental Association, South Dakota Dental Association, American Association of Facial Aesthetics, and the International Congress of Oral Implantology.
Implantology, yes, ma'am.
Okay, and the Academy of General Dentistry. I drove a school bus, okay?
That's okay.
All right. Sitting on the right, we have his brother, Aaron. And Aaron has a long list of accomplishments here. I told Aaron, I said, you've done so much. He is the owner of Illumination Dental Arts. He makes the crowns and the bridges for Dr. Mark's office. And he also is a part of the start of the denture box, which I am getting the digital 3D print dentures. He began his training in 2001 at Bates Technical College in Tacoma, Washington. And he went on to work at, how do you say that? Aurum?
It's Aurum.
Aurum Ceramic in Las Vegas Institute. He attended the Advanced Dental Study course. He went on to continue training in the Advanced Aesthetics, Neuromuscular Restoration, and Full Mouth Reconstruction. He then, in 2020, he brought Illumination Dental Arts in with his brother, and they kind of worked together.
Yeah. We share a building. That way we can work very, very closely with Dr. Mark and with the patients and myself. That way we can achieve the highest goals that we're looking for our patients.
So I just wanted you guys to know how well trained these men are. I mean, they have studied, they've put the work in the time, and how giving they are. Tonight, we're going to do a topic, and I've gotten so many questions from all of you that we've kind of narrowed it down to a topic, and tonight is going to be implants. If you have any other questions, put them in the chat, because we are watching the chat for questions that you might have also. So we kind of have a rundown of questions here, but if you have anything else you want to ask over here, feel free to ask that. So I don't know, let's start. I know when I went in and had my full mouth extraction, I was thinking about getting implants myself. I was going to do the snap-in, the snap-on, and tonight I think we're talking implants directed to snap-on dentures because they're different when they're all on 4s, aren't they?
Correct. They absolutely are different.
Now, my doctor told me he wanted me to wait at least 3 months to have the first implant placed to heal. Why? Why do you need to do it that way?
Typically, when you have your teeth taken out, there's a hole left in the bone. There's a socket in the bone. And when your body heals, the cells at the gum tissue are surrounding the tooth will grow down into the base of that socket, and then the socket will fill in with bone, with nice new healthy bone. That bone, as it fills in, kind of shrinks a little bit width and height wise. So sometimes doctors want to do what we call a socket preservation graft in order to help maintain that. But typically, that bone will fill in with nice, new, healthy bone, and that's the best to put implants in. You get the best recovery and the best healing with the implant in the bone when there's nice, healthy bone there.
Now, I'm going to just add this question to you. How, like from the very start, if I would walk into the office to the very end, about how long does it take to have the whole procedure done to where you're done? You're out of the office and you're done. I'll see you in 6 months.
Having the teeth taken out or the implants?
Now, having the implants put in and then having the snap-in dentures made, about how long is that process?
The actual surgery for the implants is just based upon your doctor and their skill level. I did one this morning where we took out 23 teeth and we put in 4 implants immediately into this patient's jaw. And we did it all in about an hour and 15 minutes.
Oh, wow.
And so it's not a terribly long and drawn out process.
Okay.
But now that patient has to heal for 4 to 6 months until we can finish their denture process. And so the actual chair time is not a ton. She'll probably be in my office 2.5 hours from start to finish. But a lot of it is the hurry up and wait time where we're healing in between.
Right.
And so that's the part that takes the longest.
Okay.
Placing an implant like that isn't like, screwing into a piece of wood. Once that implant is placed, we have to wait for the bone to actually heal and adhere and integrate with that implant.
Right.
Before we can put any forces on it.
Yeah.
Right.
And so that's really what takes the time. And especially if you have periodontal disease or something like that, we have to wait for that bone to be healthy before we can start adding any other forces or pressures onto it.
And
Right.
sometimes people are not candidates for immediate implants. If you're having your teeth taken out and there's abscesses or infections all over, the bone is just going to be angry. And even if you're able to clean that implant or clean the infection out to hard, solid bone, a lot of times just the ramifications of the long-standing abscesses create angry bone, and it just doesn't heal as well as we want it to.
Right. I do understand that because I know my mom, she just has lost a tooth on the top and she's going through a whole process before they made her a flipper tooth,
Mm-hmm.
before they can do any implants or anything. So now when you remove teeth, you have and put the implants in, how do you know where the facial nerves are?
Typically, there is really only one nerve that is really, really important when you're placing implants, especially on the lower. You do have a nerve called your facial nerve that comes up underneath your chin this way and up into your parotid gland. And that nerve allows all of the muscles in that side of your face to work. So if you hit that nerve, then you get muscle paralysis in your face, and you get drooping, and your eye won't blink, and you can't smile, and all of those things. But that nerve is not in the bone that we're working in. The bone that we're working in is your lower jaw. The nerve that's there is called your inferior alveolar nerve, and it runs in a canal that enters your jawbone back here and comes out down here next to your chin, kind of like between where your premolars are, like right in between your premolars.
Mm-hmm.
And that's the nerve that's the most important. And typically, you have to have a specific height of bone between the top of the crest of the bone and that canal the nerve runs into in order to put an implant above that canal. People who have been had severe periodontal disease, or maybe, we run into a lot where people have some front teeth and have been wearing a partial denture in the back for a long time. That bone has a tendency to saddle out. And so that space between the crest of the ridge and the inferior alveolar canal really shrinks. And a lot of times we don't have enough bone to put an implant in the back. So we have to go in between the mental foramen up here, kind of in the chin area. But the way we find that nerve is through a CT. It's a 3-dimensional X-ray that allows us to see not only the height of bone like we can see on a 2-dimensional X-ray, but also the width of bone that you can see from tongue to cheek width. and that allows us to actually visualize and mark where that nerve canal runs so that we can measure and virtually place the implants in that image and decide where we can place them and where we can't.
Okay. Now, what percentage, if what percentage of people have the nerve damage?
No, I'm sorry. Go ahead.
Go ahead.
Let's go to the office and see if there's somebody there to answer that. The percentages are hard to tell. Only recently has cone beam 3D X-rays, like we see on the screen there, become the standard of care when placing implants. And so there's been a lot of implants placed just by two-dimensional X-ray.
Right.
So in the beginning of implantology, I think that the incidences of nerve damage were significantly higher than they are now. And now there's so many things that we have available to us to help us prevent that. One of them is the cone beam X-rays, where we can actually see where that nerve rests. The other is the advent of like 3D printing and allowing us to use guided surgical systems where we can virtually place the exact size of implant and the exact brand of implant in the exact position that we want virtually on our computer, and then create a model of that to help us guide to get that implant directly where it needs to go. And so it's hard to quantify the number of nerve of damage, the percentage of patients with implant nerve damage, but it's significantly lower than what people think.
No, we have a question from the chat. Ashley wants to know, she says, I'm in the process of an all-on-4 mouth restoration.
Mm-hmm.
I have the implants already, and I'm getting zirconia arches. What are some questions I can ask the lab that's making them about material and manufacturers?
I'm going to let Aaron answer this one. He's the expert on zirconia and milled zirconia. So,
as far as zirconia goes, manufacturers, there's I would say dozens of manufacturers that make the zirconia materials that are used in that process. More or less, they are pretty much the same. The composition of the zirconia doesn't change much from one manufacturer to the other. Probably what you're going to want to look at if you're asking questions to the lab is if you can have input as far as case design, final aesthetics, the things that are going to affect the way that you look, or the way that, if you, let's say, liked the length of your original teeth, then that information needs to be given to the lab so that we can make sure that we keep that same tooth length. Or maybe you wanted them a little longer, a little wider, those kind of things. When you're dealing with function, a lot of the time the function is dictated by whatever you have, whether it be a denture or natural teeth in your opposing teeth. So if you're getting an all-on-4 on the uppers, really, it's going to be designed to work with whatever you have existing on your lower teeth, or the other way around. So materials-wise, there's the standard materials. Most of them are extremely strong, between 1,100 and 1,400 megapascals in strength, which for most of your viewers means nothing. A natural tooth is about 350 megapascals in strength. So if you're working with a 1,400 megapascal, that's going to be significantly stronger than a natural tooth. And so we use those for large bridges, for the all-on-4 cases, so that we have enough rigidity and robustness so that you don't have failures, down the road.
Okay, can I just stop 1 second? My granddaughter's in the chat. Hi, Haley. Okay, she's in the chat. I just want to say hi to her. Okay, let's go into bone grafts. If you need a bone graft, what material is used when you do that? And can you take a piece of bone out of your body to use?
Yeah, you absolutely can. There's typically 4 types of materials that are used for bone grafting. One of them is your own bone,
Right.
and that can be taken from several areas. And it depends on the kind of graft that you're doing. When I'm doing a graft at the time that I'm taking out teeth, I do what's called a socket preservation graft. And we put a particulate material down in the socket, and that gives your body a scaffolding to grow through, so that you end up using less energy, and it helps to maintain the width and the height of bone as you heal, to ensure that implants are able to be placed 4 to 6 months down the road when it's time. The materials are either your own bone, donated human tissue, which is really sterilized. It looks like little pebbles of sand almost that you can put down into the socket. There is animal bone, typically bovine from a cow, or there's a synthetic bone materials that you can use in those sockets to preserve the grafts. Somebody who's been wearing dentures for a long time and has narrow bone, you can't really do a socket preservation graft because you're not taking out a tooth and trying to preserve a socket. But those situations, you usually have about 3 options. One of them is a block graft, where typically an oral surgeon will cut a block of your own bone out of either your chin down here or the ramus of your mandible back here. And then they will screw that block of bone to a prepared site where they want to put the implant. And then it takes several months for that to incorporate before they can put the implant in place. The second option is what we call a ridge split. There's a way when you have a narrow ridge that a surgeon can kind of make an incision down the top of the ridge and split it open like a log, and pack some bone down inside of that to add width to the bone in order to be able to place implants. And the third is what we call a ridge augmentation, where you prepare a side of the bone with some burrs and some drills, so it's all nice and bleeding and gets us the cells that we want to work. And then the surgeon fabricates a custom titanium cage that they screw to the bone, and they put some material inside that cage, usually some kind of bone replacement, like a human donated tissue, or also some bone generating factors your body creates, like bone morphogenic proteins on collagen sponges inside that cage, and your body will actually grow new bone on top of the ridge in order to widen the ridge. But those are typically the kind of bones that we use for bone grafting. None of them is significantly better than the other. It just depends on the patient and what they want. And it also depends upon the surgeon or the dentist and their skill level or comfort level with each one of those. I had a patient one time she said, I'm a very strict vegan and I cannot use human bone or animal bone. So we had to figure something else out. So sometimes it's preference, and sometimes it's your doctor's preference, but they all kind of work the same. The last place that you can get bone from to do a graft is from your hip. You can actually take it from your iliac crest on your hip down here. That typically is a little more complicated and doesn't happen in a dental office, has to go to the OR in the hospital to get that taken care of. But that bone works beautiful as well.
Oh, good. Okay, we have a question from Lily. After getting a tooth extraction, would it be wise to have the extraction hole filled with cadaver bone? Would it prevent your jaw from falling,
yeah, or shrinking? It depends on if you're going to get an implant put into that site. If you're trying to do it to prepare that site for an implant down the road, then yeah, it absolutely makes sense. If you're not getting an implant placed in that site, it doesn't make a whole lot of sense to try to preserve that bone if there's no reason to preserve it. Typically with cadaver bone or donated human tissue, it really only lasts about a year. And if you don't get the implant placed within that year, that socket will catch up, and it eventually will look like a socket that was never grafted to begin with. And so that bone doesn't just stay around forever. You have to do something with it. And if you know you're not going to get an implant placed in that site, then I tell my patients all the time, it's not worth spending the money to graft it, because a year or two down the road, you're not going to be able to tell the difference.
Now, a year or two down the road, if I decide I want implants, will I have a problem doing that?
It just depends. It depends on how you heal and how fast your bone recedes. We have had patients who have gone from beautiful, healthy ridges to almost nothing in a couple years' time. Or we've had patients who have worn dentures for 50 years and they still have big, huge, healthy ridges that look like the teeth were just extracted. And that's the challenge for us, is that we can't predict how somebody's going to heal. We just don't know. And so if you think it's an option, it's always better to do it sooner rather than later, because you may end up working yourself out of that option if things heal too quickly or too fast, and you just don't have enough quality or quantity of bone.
Now, do your gums shrink with the bone grafts? Do they still shrink?
Yes. So when you get an implant placed, the implant tends to work like the root of a tooth. And it will, once you load that implant, which means put pressure on it, then it will actually stimulate the bone that it's connected to, and it will send a signal to your body that you're using that bone, and then your body will spend the energy it needs to maintain the bone, just like the periodontal ligament does on a natural tooth. And so anywhere where you have implants, the implant typically helps to hold the bone in place, whether it's a single tooth replacement or whether it's 4 or 5 or whatever implants to help hold a denture in place. The gum tissue will continue to recede, but the gum tissue only follows the bone. So if the bone recedes, the gum tissue follows it. And so anywhere where you don't have an implant placed, that bone will continue to recede for the rest of your life. So if you had a partial in the back for a long time, and we didn't have enough space between the crest of the ridge and your inferior alveolar nerve to place an implant back in the back, and we only put 2 or 3 of them up in the front, then the back where that denture is resting will continue to recede.
Yeah.
Okay.
Any areas of bone, where it doesn't receive stimulation, your body is going to reabsorb that.
Yeah.
It's not going to spend energy, nutrients to maintain some part of it that's just not being used.
Yeah.
And
your body doesn't necessarily wake up and say, look, we need to actively remove this bone. It just stops the maintenance process. And the way your body works is it spends the energy where it's getting the signals from. And when you don't have a signal from either an implant stimulating the bone or a tooth stimulating the bone, then your body just stops the maintenance process.
Right. Now, if you knew down the line you were thinking you wanted implants, how often would you, like your gum care, would you go to your dentist once a year, every 6 months, and have them check that? Is there a way to check that?
Your gum tissue that's over the top of the bone can be very deceiving. You can look in somebody's mouth and see a nice thick ridge, but then look at a CT X-ray in cross section and see that the bone is actually very thin and you just have thick tissue. So really the only way to accurately measure that bone and to keep track of that bone is to continue to do X-rays, and that's not terribly healthy. I recommend for my patients that I want to see them once a year because I want to do a good oral cancer screening. I want to make sure their dentures are fitting like they're supposed to, and make sure that we're doing everything we can to help maintain their quality of life. But there's really nothing that we can do short of taking radiographs to check the health of the bone in places where we think we might put implants.
Okay. All right. We have this is a good question. I'm getting snap-ins next week with metal bars. Will I set a metal detector off?
You will not. Typically, no. Titanium typically does not do that. It's just like a hip or a knee replacement. It's all made out of the same metals.
Right.
So sometimes your dentist or your oral surgeon can give you a little card that when you're going through a airport screening area where you can say, look, this is what I have in my mouth and it's okay. But typically there's no challenges at all with metal detectors. The metal is also not magnetic.
Right.
So you can have dental implants in your mouth and still go through an MRI or any of those kind of things, and it won't pull that metal.
Right. I have titanium in my neck, and I have a huge titanium rod in my spine. I can promise you I don't set anything off.
Yeah, it's the same. And honestly, with the little amount of metal that's really in your mouth compared to other places, I mean, you might have a bar that long compared to a hip replacement this long.
Right.
And it just is not going to create any problems for you. You can live your life as normally as possible.
Right. All right. Now, what are the stages of getting an implant for snap-in dentures?
So the stages are the same whether you do it immediately or whether you do it afterwards, like you want to do, Michelle, where you're waiting a few months to put implants in. It doesn't really matter. The stages are the same. You either put the implant in right when you take the tooth out, or you wait 3 or 4 months and put the implant in. But either way, the implant still has to heal. If it's a conventional implant, we typically want it to heal 3 months or so, 3 to 4 months. So before we actually put any loading pressure on that. And if you put pressure on it too soon, you have the probability that you're going to create some movement in that implant, and it can cause the implant to fail. There are some systems out there, like I use a system made by a company called Zest Dental Solutions. They have a system called a LODI, L-O-D-I, and it stands for lower over denture implants. And sometimes with those systems, when you're not extracting a tooth and immediately placing that implant, if it goes in tight enough, you can snap the denture down to the implants the same day. That's not typical. And so the process is you get the implants placed, you wait the 3 or 4 months until things are healed and the implant is integrated into your bone. And then you either retrofit your existing denture to those implants, which we do all the time, or you get your new denture made based upon where those implants are placed.
Okay. And I don't know, abutments, the abutments come later.
Mm-hmm. It depends. If you're using a system like the LODI system,
okay,
you put the abutments on at the same time. And there's different kind of abutments. There's locator abutments, which are made by Zest, which are used by almost every dentist in the country. And then you can use like a ball attachment or whatever, and it just depends on your specific situation and the kind of implant system that your dentist is using. But when we put a LODI implant in, the abutment, the locator abutment goes on right away. When we're placing a conventional implant, it just depends on how tight the implant goes in. If it goes in nice and tight, then you can put an abutment on it right at that same appointment. If it doesn't, then we put a cover screw over the top of the implant and we sew the gums up over the top and we let the implant heal underneath the gum tissue. In that case, there will be a stage 2 surgery where you go and make a little incision above the implant and then you place the abutment on top of it and allow the tissue to heal around it. That abutment will kind of act like an earring in a pierced ear, and it will heal the tissue in a circle above the implant so that we can unscrew any kind of attachment or abutment that's on top of it and access the implant beneath without anesthesia or the need to cut you open every time.
Okay. All right. Now, how do you care for the implants?
Implants are just like teeth. They're a hard surface in your mouth, and the bacteria in your mouth have the same access to those as they do your teeth. You may or may not be told by your dentist. Sometimes, especially if you go to a place that only does implants and they don't do any of the maintenance, sometimes people don't talk about that part of it. But because the implants are affected by the bacteria the same way, you will never get a cavity on an implant. It's made out of titanium and metal, so you don't have to worry about that. But you still can get bone loss around an implant, just like periodontal disease around a tooth. The attachment to the bone is different than a natural tooth is. So just because you had periodontal disease doesn't necessarily mean you will lose bone around your implant. It's called periimplantitis. Just because you had periodontal disease doesn't mean you're going to get periimplantitis. but it does mean that you still have to take care of those the same way you did natural teeth. You have to brush them a couple of times a day. You have to take your denture out and really take care of your denture and maintain your denture as well as the implants to prevent tartar buildup and those kind of things from happening. And I tell my patients with implants, we still want them on a regular maintenance schedule. I want to see them every 6 months. I want to make sure the implants are holding up very well. I want to take x-rays of those implants once a year just to maintain that we know we're maintaining the bone around those. And the thing with implants is, once you start to get a little problem or some peri-implantitis around them, the sooner you intervene, the better chances you're going to have of saving the implant.
Okay. Okay. And I think that's all the implant questions we had tonight. Oh, we have another question, Rob said. Where's it at?
Lily water. Would you recommend 3 to 4 on 3 on 6?
All right. Can you guys see Lily's question? Because I can't.
No, I can't see any questions.
All right. Hold on. Oh, Rob's going to from who?
Okay.
Lily water.
Rob? Oh. What would you recommend? All on 4s or 3 on 6?
Okay, let me see where she's at. Let me see if I can find that question.
She's up about 20 Chad.
Yeah.
20 messages.
What's the name I'm looking for?
Lily.
Lily.
Lily water.
We found it. She wants
What
to know.
would you recommend? All on 4s, 3, or 6? Okay, so there's a saying in dentistry when you're talking about an all on whatever situation is that you either have all on 4 or you have nothing on 3. Okay, so if you're looking for an all on 4 situation where you screw a denture down and it's not a snap in or out denture, the more implants, the better. So when we're doing those, we try to never place 4 implants. We always try to place 5 or 6 implants, because there's always a chance that one of those implants is going to give up on us. It's going to fail. And if you have only 4 implants and one of those implants fails, it typically means that you got to start all over again. You got 6 of them in there and one of them fails, then you don't necessarily have to stop treatment at all. You just keep moving because there's still enough implants in there to hold the denture in place. And so if you just remembered you got all on 4 or nothing on 3, the more implants, the better. So when we're placing these, we try to do 6 if there's space.
So we definitely recommend not 3.
Yes. Now 3 is good for a snap-in denture. Snap-in dentures are a little bit different. Typically, the minimum that you need is 2 conventional implants, or typically 4 mini implants or narrow diameter implants. A lot of times we like to put them kind of where your canine teeth are if you're just doing 2. Well, if you do 2, it creates a situation where there's a fulcrum line between those 2 implants, and the denture wants to rotate front to back like this all the time. So I typically recommend, if you're doing conventional implants, that you do at least 3. 4 is better. Sometimes there's not enough space to place 4, but you want to have 3 implants so it gives you kind of a tripod effect. So you have kind of 2 where your canines are or your premolars are, and then you have 1 in the front, and that prevents the rocking back and forth all the time and makes your denture significantly more stable for a snap in or out denture.
Okay. Can the snap-in denture undo, and do you have to renew them?
Yeah, they can come out on their own. When you have a snap-in denture, the system that I use is the Zest system with a locator attachment. And it's just like anything else in the world. There's moving parts, and the more you move them, the more that they're going to wear out, just like car maintenance or anything else. And so there's 3 components to a locator attachment. There's the actual locator abutment that screws to the implant. There's a metal housing, like a female counterpart, that goes inside the denture. And then inside that metal housing, there's a nylon insert. And that nylon insert is the part that really wears out the most. If your surgeon or your dentist is able to get your implants really pretty parallel to each other, you may have to change out those inserts once or twice a year. Not terribly expensive, and it's not terribly often, and it literally takes 2 minutes in my office to pull the old ones out, put the new ones in, and you're back on the road again. But they're just like anything else. They have moving parts and pieces that need to be updated and replaced, with time.
And not only that, they're, having the implants placed absolutely parallel is an ideal situation. We're dealing with people's individual biologies, and sometimes getting those implants placed perfectly parallel just is not an option, depending on where the density of bone that you have in your mouth, where we can place them and where we can't. And so if they're not absolutely parallel, then you're introducing a little more wear force, and you may have to have those things, those inserts replaced more often, just because they're not working in an ideal situation.
So what's on the screen right now is a locator attachment. So that's what goes on top of the implant. And the little blue piece that you see is that little nylon insert that's on the inside of that. The system has a built-in angulation to it, where you can have the implants divergent or convergent to each other up to 20 degrees and still work fine. Once you get outside of that 20 degrees, then you either have to use a different system, or you have to figure something different out. But the more angulated the implants are, the faster the components are going to wear out. But just because you have angled implants, it doesn't mean there's anything wrong. It doesn't mean that your surgeon or your dentist did anything wrong. A lot of times on our end, we have to put the implants where there's bone. And if there's not bone in a certain area, then we kind of have to work around that in order to get an implant placement done. And so sometimes we can't put them exactly parallel because of other structures in your face. And so we do the best that we can. But the closer to parallel those implants are, the better they're going to be, and the longer the parts are going to last.
All right. Now, I had a question asked to me a while ago. Do you still have to do soft relines and use adhesive when you have snap-in dentures?
The goal is no. That's the whole point of the implants, is that you don't have to use adhesive.
Right.
I don't have any patients in my practice that I know of that are still using adhesives that have a snap-in denture. If you have a snap-in denture and things are not snapping like they're supposed to, typically it means a component is worn out. You need to go back to your dentist and have that component replaced, and it should work beautifully just fine. The adhesive sometimes comes into play when you only have two implants on the lower and you have that rotation around the fulcrum line that we talked about earlier. Sometimes people in that position want to put a little adhesive in the back of the denture to help hold it down while they're eating, so that you don't get the rotation around those implants. But typically you don't need to have adhesive to hold your denture in. A snap-in denture is what we call an implant retained tissue-borne prosthetic. It means that the implants do all the work of holding the denture in, so that you're not necessarily flipping it out with your tongue, or it's not flying out while you're yelling at your kids or talking to your friends or whatever. But when you bite down on the denture, the tissue and the ridge still bears the weight of function on that. Otherwise, if it's an all-on-4 or 6 or whatever, then that's an implant retained, implant-borne prosthetic, where the denture doesn't touch the tissue at all, and the implants do 100% of the work. So those different prosthetics work a little bit differently. But sometimes you have to use a little adhesive if you only have two implants and the thing rocks back and forth. Typically, if you have 3 or more implants on a snap-in denture, you don't need adhesive anymore.
Yeah, but I mean, my goal to get in the snap-in denture would be I don't want any rocking. I want them there.
Yeah.
I want to be able to count on them and be there. Samantha wants to know if you can wear your snap-in dentures all night long.
You can, just like you can just conventional dentures, you can. The thing to remember about that is your mouth is a living structure, right? There is lots of different bacteria and viruses and proteins and fungus and all kinds of things that live in your mouth naturally that are kind of fighting each other for space, and they kind of keep each other in check all the time. So if you put a denture in and it covers your tissue, you're changing the environment of your mouth. And typically when you put a denture in and you wear it all night, or you don't take it out at all, or any of those kind of things, then you change the environment in your mouth to favor fungus. And so you end up getting thrush or fungal infections significantly more often than if you took your dentures out at night to let that tissue rest and breathe and kind of reset more of a natural way. So I tell my patients all the time, take your teeth out while you sleep if you can. Sometimes people can't. If you have an upper denture, a natural lower dentition, a lot of times as you kind of clench and grind at night while you're sleeping, your lower teeth just chews your upper gums up, and you have to keep your denture in order to protect yourself. Sometimes people, when they have like a full set of upper and lower dentures, when they're completely out, their jaws cannot touch each other, which is a normal situation. And then if you're grinding or trying to clench at night in that situation, you can really stress the ligaments in your joints. And so in that situation, I recommend people keep their dentures in at night. If you're healthy and you don't have to wear your dentures at night, it's advisable to take them out and allow the tissue to rest. If you can't, then I tell them, look, whenever you're doing your normal daily routine, if you get up and shower in the morning and have a cup of coffee and all of that kind of stuff, read the newspaper or whatever, take your teeth out and allow your tissue to rest during those times. If you do that same process at night before you go to bed, do the same. That's when you can put it into a denture soak or a cleaner to help clean the denture or whatever while you're showering and doing your normal daily routine. And then clean them up, put them back in before you leave.
Okay, we have another question. Kimberly wants to know, is it better to have them put in permanently?
It just is different for every person. There's pros and cons to each of those situations. In my life, I would sell my house or my car or my motorcycle or whatever I needed to get a screwed in denture, because that's as close as we can get to natural dentition and natural function. And the things in my life mean nothing to me. I value experiences and things with my children and my wife and my family. And I would sell my things in a second to have the experiences, but that's not what everybody values. Sometimes people who have worn dentures for a long time in my practice are really comfortable taking things out and having something in their mouth screwed in that they are not able to take out on their own really freaks them out. And so typically what we see is somebody who has a terminal dentition where they have natural teeth that are failing and they're going to be moving into dentures. Those are the people that are much more apt to choose a fixed screwed in denture than somebody who's been wearing dentures for years. Typically does not go to a screwed in denture. They just typically want something more stable than what they have. But honestly, it's a personal choice. One is not any better than the other. You just have to kind of decide what's going to work in your life and your lifestyle and go with that. But there's pros and cons to each, and your oral surgeon or your dentist can talk to you about the pros and the cons of each. The biggest difference is expense. To get a snap-in denture, you might, implants and denture or whatever, you might spend $10,000. To get a screwed in lower denture, you might spend $30,000. And so there's a huge difference in investment, but it depends on what your goals are as far as quality of life afterwards.
Right. Richard wants to know why he can't replace the O-rings by himself.
Well, I don't have a problem with you doing that. You got to find a dentist to sell you the parts and pieces, because the companies that make those O-rings, it's a medical device. They're only allowed to sell it to people who have medical licenses or a dental license, just like any other dental materials or medical materials or medications or those kind of things. And so if you're comfortable with your dentist, talk to them. I've done it before. We have patients who, live 2 or 3 hours away from town. Rapid City, where we're at, is kind of our little geographic center, but we're geographically isolated. Our biggest large city is Denver, and that's a 6-hour car drive away. And so we pull from large populations of farmers and ranchers and those kind of people that don't want to drive 2 hours each way to get their little O-rings changed for a 2-minute appointment. So all the time we give parts and pieces to people and teach them how to do it and let them go. So it depends on what you want to do. But I don't have a problem with my patients changing their own O-rings as long as I teach them how to do it right.
That's funny. Okay, this is a good question. Ashley says, I don't know much about this, but what are guided implants versus non-guided implants, and does it matter?
The implants are the same. The implants don't change between a guided system and a freehand system. It really just depends on your dentist or your surgeon and what they're comfortable with. Guided implants are where we take your 3D X-ray and we take some models of your mouth and we and some models of your denture, and we build a three-dimensional a guide that is it's fixed to your bone, right? So they'll make an incision a lot of times in the gum tissue, peel the gum tissue back, and then they'll put this implant guide on the bone, and they'll kind of fix it to the bone with fixation screws. If you're doing a full arch that way, that's how they'll do it. If you're doing a single tooth implant replacement, then they'll use your natural teeth as the base for the guide. But the guide is system specific. Every implant manufacturer has their own guided system for their own implants. But what it is it allows you to virtually place the implant in the three-dimensional scan in an exact position and an exact angle with an exact implant. And then they transfer that to the guide, and you use a guided system to get that exact implant in the jawbone in the exact position. And so you can set things up very, very quickly and easily, and a lot of times it makes surgeries faster that way. That there on the screen is a guide for a couple of implants where somebody who has natural dentition is just replacing a couple of teeth. And so you can see the holes for the guide on the bottom right hand side of that picture, but the rest of that just connects to their natural dentition. I don't do a whole lot of guided implants in my office. I typically do freehand implants that way, just because that's the way I was taught, and I've done thousands of them that way, and that's just what's comfortable to me. But honestly, you can get the same outcome with guided or without guided with implants. So it's completely up to you and your surgeon on how you do it.
A guided system is great because you can be very, very precise. That guide only allows you to work in the space that it's been designed to allow the dentist to work in. But with anything, if your dentist is not comfortable using a guided system, your results are going to be less than optimal. It would be better to have your dentist work with whichever system they're comfortable working in.
And the thing you have to remember is when we're working inside the mouth, we're working with very small measurements. We're working with millimeters or fractions of millimeters. And so if you have a spot where you need to put an implant, but you're only a millimeter or two away from a large structure like a sinus or a nerve, and there's not very much room for leeway, guided implants are the best in that situation because it will not allow you to go further than what the guide has designed you to do. And so it really just depends on the situation, but you can have beautiful outcomes with either a guided implant system or a free-handed system.
Okay. I think that is it. And
I have a question that Jen gave to me. It says, okay. I don't know who asked it, but it says, can you get permanent implants once you have a snap-in denture implants?
Oh, that's a good question.
That was from Simply Jan Homestead.
From Simply Jan Homestead, it says.
Jan has very new snap-in dentures, and she looks beautiful.
Good. I love that. It's a very complicated question, though, okay? Because the systems are completely different. And when you have a snap-in denture, because it's an implant-retained tissue-borne prosthetic, you want as much ridge height as you can get to maintain so that the denture has enough ridge to function on. Because the ridge still bears the weight of the function, and the implants don't really do a whole lot except for retain the denture and keep it from flying out of your mouth. When you have an all-on system where it's screwed in, you need 15 to 17 millimeters worth of prosthetic space. So a lot of times when you are getting an all-on system, we actually remove a lot of bone from your ridge so that we can get the platform of the implant in the exact position that we need to make the denture tall enough to have the right amount of strength.
Mm-hmm.
And if you have a system where the denture is snapped in and you have a tall ridge, you may not be able to convert those same implants to a screwed in option down the road because you might not have enough room for prosthetic space. So if you have a tall ridge on a snap-in denture and you convert it to a screwed-in denture, your teeth may be sticking up or down that far because that's how much space they need to make the prosthetic. And so a lot of times when we have patients who want to go from a snap-in denture to a screwed-in denture, a lot of times we have to remove the old implants, start over from scratch, and put new implants in based upon the bone height.
That was a really good question.
Yeah, it's a very complicated answer, and I hope that worked for you, Jan. But sometimes you can, sometimes you can't. If you have had, I was working with a dentist in Nebraska earlier this week, and he was going over a case with me where he wanted a little bit of input, and he was going to put 3 implants into a patient who wanted a snapped-in denture, but was going to try to convert that to a screwed-in denture within 5 years when he had the finances. And so when we have a situation like that, then we know we're going to convert down the road. We place the implants with the prosthetics in mind, right? It's a prosthetically driven implant placement. And so at that point we say, okay, place the implant where you have enough prosthetic space and then make a denture to snap to him. But then when he's ready to convert the implant, the bone height and the prosthetic space is already there. The other way that it can work is if somebody's been wearing a denture for an extended period of time, like my mother-in-law wore them for 20 years and her ridge was pretty receded. And when you're placing implants in that situation, you don't have a tall ridge anyway. So there's plenty of room for prosthetics down the road if you choose to change things out. But the real challenge is if you have a high ridge height because you're trying to preserve the bone for a snap-in denture, it may not work to convert down the road because there's not enough space to make a screwed-in denture in that space.
Now we have the opposite question. Do people ever change from screw retained back to snap-ins?
Absolutely they do. And I think that happens more often than people with snap-in dentures converting to a fixed screwed-in denture. With a screwed-in denture, there's an awful lot of maintenance involved. You have to get the denture taken out. I tell my patients every 18 months, we unscrew that denture, clean the implants, clean the denture, make sure everything is okay. Every 3rd cleaning appointment. So they'll have 2 6-month checks where we clean the implants around the prosthetic. The 3rd one, we take it out. And sometimes people cannot maintain the home care that is needed to keep the implants from failing or to keep peri-implantitis from happening around those implants. And a lot of times in those situations, either the patient requests it or the dentist says, if we don't convert you to something you can take out, you're going to lose all of these implants. And people sometimes think that an implant is just a one and done deal. You put it in and you don't have to think about it anymore. And it's not the case. A lot of times people think that when they take all of their natural teeth out and they get the dentures, they just get to retire from dentistry and don't have to see their dentist anymore. But really, you're just trading one set of problems for another. You're trading your teeth problems for your denture problems. And you still have to have oral cancer screenings, and your bone still recedes, and you have to have relines, and dentures wear out, and teeth bust, and all of those kind of things. And so you still have to see the dentist, even though you have dentures, or you still should anyway. And so a lot of times people who have screwed-in dentures that can't maintain the home care and the maintenance that is required to keep the implants from failing and to keep them healthy can absolutely convert to a snapped-in denture in that situation.
Then she wanted to know, what is the cost if you would break something and somebody can't afford to fix it? What do you do?
On a conventional denture or a screwed-in denture?
I think she was talking, the same person from the same question. So,
Well, there's different materials that you make a screwed in denture out of, and I'm assuming that's what she's talking about. You can either have like a titanium bar that's wrapped in a normal denture acrylic with denture teeth, or you can have some nano ceramics made where you have a metal bar and you actually glue the teeth on that metal bar like individual crowns, or you can have like a full milled zirconia prosthetic, right? And sometimes those things break. If it's an acrylic denture, they're going to wear out just like acrylic teeth do. The process to fix them is very simple. You just unscrew it, take all of the teeth off, put new teeth on, and off you go. Take a couple of days to get it done, but the bar stays the same and the implants stay the same. And when my patients come in and do that, I give them their temporary all-on-4 denture when they're done, and I say, keep this in a safe place. Something breaks, we have them come back in. We screw their old temporary denture back in so they have something to wear while we're fixing what they have. So we unscrew the one that's broken, screw the temporary denture in that they started with when they had the implants initially placed, tell them to go about their business, and then we fix whatever we need to fix, either an acrylic denture tooth or a porcelain crown that needs to be replaced. Or sometimes zirconia, full milled zirconias can fracture, and we have to mill a new zirconia arch, a full arch, and you can't really do that inside somebody's mouth. So we always screw their temporary one back in and keep moving. And the cost of that depends on what the challenge is. If it's just a denture tooth that needs to be replaced inside an acrylic denture, the cost is very minimal. It might cost you $100. If you have to re-mill an entire new zirconia arch, you might spend 10, 12 grand on something like that. And so those are the things you have to keep in mind. It's not a one and done deal. And if there's any issues down the road that need to be addressed, all of that expense or that investment is incurred by our patients.
okay.
The hard part for me is that it's hard for our patients to understand that the things that they're born with don't last forever. But in dentistry, it seems that when somebody writes a check for something, they want it to last forever. And the challenge is that your mouth is a very violent environment. Those things are colliding with each other all day long.
And all night long.
Yeah. And we do the best that we can to make something last for as long as we can. But everything has a shelf life. You might get 10 or 12 years out of a full arch of zirconia before it breaks. You might get 30 years out of a full arch of zirconia when it breaks, but you have to be prepared for that to happen down the road. Typically in my office, if it happens in a very short period of time, we don't charge our patients for it at all because it's something that we stand behind our products. Not every dentist does that. But if we have a patient come from another office that has a full broken zirconia, they're going to pay full price for a new one, which is almost 12 grand in my office.
Right. All right. We have another. Did Aaron have something to say?
Oh, I was because a lot of patients can't relate cost to their medical devices. I always liken it to cars. It depends on how much you want to spend for how much performance and how much you want to maintain it. Yeah. If you buy a Honda Accord for 20 grand, it's going to give you a level of poor performance, which is great. And maintenance is going to be pretty easy. If you buy a Lamborghini, it's going to cost you a lot of money. You're going to have tons of performance, but it's going to be a lot of maintenance. Yeah. And either way, you're making an investment. The level of maintenance has to be there to protect your investment. You're not going to buy a $80,000 work truck and then just drive it 100,000 miles and never change the oil. The maintenance has to be there in order for your prosthetics to maintain their performance.
Yeah. Okay, we have two questions. One of them is, I have a really small jaw, and my last denturist made special plates for my molds, and then she has $3 signs. My current dentures still fit well, but are dull. can my current set be built on for sharper edges?
If there is acrylic teeth in the dentures, typically not. There really is no way to remove the teeth and put new teeth in a full denture base, or to sharpen the teeth that are on her existing denture without going through the same amount of time or money as it would cost for a new set of dentures to be done. So typically in that situation, when somebody comes into my office that way, I use their old dentures as an impression tray, and I actually get the impressions inside their dentures to give me a great starting point, so that I can, and if they love the way their dentures fit, then I can make their dentures fit the same way with new teeth on them. And then I tell them to keep their old denture as a backup set in case something breaks. They got something they can put in their mouth. But typically trying to replace all of the teeth on the denture is a harder lab process than making a new denture, and it's going to cost just the same amount of time and money as a new denture would.
Yeah, I mean, it'll probably cost you more to try and do that. I mean, your laboratory is going to look at that and go, this is going to take me 3 times as much as a regular denture. I'm going to charge you 3 times as much as a regular
Look at
denture.
that last
Wait,
comment.
do you see the comment, Lily? She says, I'm getting out my Dremel. Lily, don't put Dremeling on your teeth to make them like a vampire.
Individual dentures better.
Yeah. Okay. So what was your other question?
I think that was it
Oh,
on that one.
okay.
The other one was Lily's wanting her teeth sharper.
Yeah. Yeah. You can't sharpen your teeth. We have a question here by Ashmack that asks, are 3D and digital dentures better than conventionally made dentures? And I think that's a great segue to what we do. Conventional dentures, when they are processed, they're processed in hot liquid, and there's a lot of shrinkage that involves in the denture base curing. But they've been around for years and years and years.
I'll be right back.
That's okay. I'm going to keep talking. And so, hey, Rob, how you doing? And so, there's things that we do that to make up for the shrinking and the polymerization process of the materials. But it means that sometimes things are a little less precise than we want them to be. In a 3D printed denture or a milled denture, all of that shrinkage is gone, so we can get a significantly better fit with a 3D or a 3D printed denture than we can with a conventionally processed, heat processed denture.
So, but as far as durability, strength, usability, the conventional acrylic dentures are very good, and the 3D dentures were really designed to either meet or slightly exceed the strength, the durability, all of those of the materials that have already been used. But the real difference is in your initial fit. Traditionally processing a denture just is not as accurate as designing one digitally and either printing it or milling it.
Okay, can I add something? Because I just went and got my try-ins that you guys are making for me, denture boxes making for me. You were able to custom the front and the back to a different mold because the back of my mouth is so high that this was a custom set. And you were able to do that through your 3D printer.
Well, her new try-ins are actually on their way.
Correct. Yes,
Yeah.
we actually were able to do that. Jen just told me to tell you that your new try-ins are on the way.
Oh,
They,
yeah,
they must be
excited.
they must be in the mail.
Yes.
But anytime we're able to do something digitally, a lot of times our software allows us to merge different impressions or different things together to give us the best parts of each one of them. The goal is always to get the best impression the first time that we can. If we can't do that and we have to have multiple impressions, a lot of times we can merge those impressions to use the best portions.
But I was impressed that when Jen said, well, we're just going to merge the front and the back together and make it a custom for you, and I know she's working on a custom one for somebody else too. So I was really impressed with that.
Yeah, that's one of the great advantages of a digitally designed system. We can take multiple scans of an object and put them together. It's still not as good as one really good impression, but in most cases, it's close enough that we can make it work.
Correct.
Yeah, I was impressed, and you guys will see a video when these try-ins get here to me. I'll make another video on that and talk about how they were merged. What'd you say?
Said it was harder than it sounds.
Yeah,
Well, I know, but you know what? I was impressed that you guys took the time to do it, and you cared enough that it would fit me right.
The one that said it was harder than it sounds is actually our denture designer in the other room. He's just making a smart
I
comment
think
for us.
he's in the comments maybe.
It's,
There,
it's super easy for us. It's not as easy for him.
Yeah.
yeah, but you know what? He did it. I was impressed.
Yeah, and James does a great job.
Oh,
Great job.
she wants to know what the price difference is between conventional and 3D.
If you go to a dentist office and you get a conventional denture or a 3D printed or milled denture, the cost may not be any difference at all. It just depends on the doctor's lab bill. If their doctor's lab is charging them more for a 3D printed denture than a conventionally processed denture, then your cost is probably going to be more for a 3D denture than a conventionally processed denture. And when you go to a dental office, prices are different all over the place, and it really just depends on the doctor's overhead and what they have to pay in order to get the denture made. In our business, in Denture Box, the cost of a 3D printed denture from us is significantly less than a cost from a 3D printed denture from a dentist. In my office, a denture, a 3D or a conventional denture is going to cost you just a little over $1,600 for one denture. Okay. Through denturebox.com, it's $5.99 for one denture, and it includes an adjustment kit, and it includes a doctor's teleconference to make sure fit's correct. It includes the ability of our denture consultants to be with you every step of the way and walk through it and all of those kind of things. But you get the same denture that you would get in a dental office for $1,500, you get for $5.99.
Yeah, and that's the way it is with anything that a lab provides a doctor's office, whether it's a crown, whether it's a partial denture. The actual object that we provide to the doctor's office is a very small portion of what it costs that doctor's office to treat the patient and place whatever the prosthetic is. And that's one of the great things about Denture Box is we're removing a lot of that overhead. But still the same thing. I mean, the cost for us to produce a denture is quite a bit less than what we're charging our customers because it requires a lot of work, a lot of information gathering, a lot of designing to create a denture that's going to work well. It's not just the cost of the resin and the cost of the teeth, in the denture that goes into making up the entire product.
Right. And everything comes like in this box. Everything comes back and forth in the same box.
Now we have some boxes behind us back here. That Jen has been so diligently designing over the time we've been developing this process. But you'll get different boxes from us. The try-in box is going to be significantly smaller than the impression box that has all of the impression materials and trays and all of those kind of things. But it makes it a little bit easier for us to make the investment for our people smaller through Denture Box because we don't have high rents and we don't have staff members that we have to pay, and we don't have all of those kind of things. And so when you're going into a dentist to get a denture, you're paying for overhead in that practice. When you go to Denture Box, a lot of that is resolved and gone before we even start.
Right. And you pay shipping because all I have to do is walk this out to my mailbox and my mailman takes it.
Yes, ma'am.
You know, and it comes back and forth.
Yes, ma'am.
We don't want shipping to be a hindrance to our customers to getting their prosthetics that they
Yeah.
need.
And honestly, the design of our business is not necessarily to compete with dentists. There are a lot of people out there who don't want to do anything from home. They would rather have a professional help them. And those people should go to a dental professional and have some help. The people that we have a tendency to help the most are either ones who cannot afford to have a denture created in a dental office, or the ones that have terrible fears of dentists or have had terrible experiences with dentists and don't want to go into those offices and have those experiences again. We've set up a system with Denture Box where you can have a denture consultant walk you through every step of the way and be very kind and accommodating and all of those kind of things and have a great product at the end. And our goal is that all of those people who don't want to go to dental offices or even with the state of our world and I mean, I still have patients that refuse to come to the office because of coronavirus. People sometimes are afraid to leave their houses or whatever. Those are the people that we're really trying to get to so that they can have some quality of life and some self-esteem and those kind of things that we really need them to have a normal, healthy relationship with people.
Well, in the amount of people now walking around without teeth, just since I started this channel and all the comments and messages, everything I get, it's heartbreaking. People that can't afford dentures, that this is brought to them now that maybe they can afford it now to have teeth.
Yeah.
You know.
Yep. I absolutely agree. Sometimes if you need a $1,500 denture and you have to decide whether you're going to feed your kids or buy a denture, those are hard decisions to make for some people. And really, we're trying to reach the people that don't have that access to care and give them a good, high quality product for as inexpensively as we can so that we can remove those barriers from people that have to make hard decisions in their lives.
Right. Well, guys, we're a little over an hour, and I thank you so much.
Absolutely.
I thank you so much for coming and educating all of us. I appreciate it.
Yeah,
It really was our pleasure.
And we'll do this again, maybe soon. We'll set up a date. And I'll let everybody know, and I'll let everybody kind of know what the next topic's going to be. And if you have any questions, my email is in the description of this video. You can email me. I have a Facebook group. You can join and message me. Denture Box, their website is also in the link in the description. You'll see a link along with all the good stuff about these guys I wrote in there. So thank you so much for joining me tonight. I appreciate it.
Yeah, absolutely. Thanks for having us. It was our pleasure to help, and we can't wait till next time.
Thank you, Jen. Thank you also. I know you're around the corner there. Thank you. All right. Thank you. And we will see everybody next time.
All right.
All right. Bye.